guests, what we're gonna do right now, we will mute everybody until Dr. Yasmeen finish up her presentation, and after that, we will allow everybody actually to ask the questions and to have a bit of discussion. Now, just to let you know that we are excited to gather you in this session. We would like to have fulfilling some of the objectives for today's session. We would like to go ahead and explore some of the recent advances in emergency medicine. We're going to discuss that through challenging cases. Would like to share this with you, having a bit of exploring best practices and optimizing the patient outcome according to the case which will be under discussion today, inshallah. We're going to try to enhance some of the interdisciplinary team evaluation, and we'll try also to foster a culture of continuous learning throughout the case. So without a further ado, I think we can actually dive into the case itself and have a bit of insightful discussion by the end of the case. Dr. Yasmeen, the floor is yours. Go ahead.
Thank you, Dr. Saad. Good evening, everyone. I'm glad to present this first grand round for all of you. As Dr. Saad mentioned, me, Dr. Yasmeen Alharmali, and my colleague, Dr. Fatima Alrawahi, will present to you a challenging clinical case with recent evidence-based medicine practice to help all of us to help our patient in a better way. So in this grand round, we'll talk about the patient we saw in Nahda Emergency Department. We'll present to you all what you need to know about this patient. And then we will talk about recent evidence-based medicine clinical decisions. What should we do? What should we stop doing? And then we will challenge you with some beyond the usual presentation in this scenario. And then we will sum it up with a follow-up to the patient story. And then finally, we'll conclude it with take-home messages. So we'll make sure everybody take the idea. So our story started in a very busy night shift when a man was brought inside the department on a wheelchair with a vomiting bag in his hand, placed in the treatment beds in the department. The man was placed in the treatment bed in the department, and we went to take care of him. So this man name is Ahmed. He is a 46 years old male known to have diabetes, hypertension, and asthma. He had no surgical history. He had no liver diseases before. He is not a smoker or alcohol consumer. Actually, he was well and fine till 11 p.m. that day when he tried to eat a new food. He ate endomy. So he was okay after the food immediately. Then he went to sleep, but he woke up at 3 a.m. with severe epigastric pain and start to vomit continuously. When the family saw that nothing helped him to release his symptoms, they decide to brought him to our A&E early morning that day with similar symptoms. So at presentation, his blood pressure was in the higher side, a bit tachycardic with heart rate of 101, febrile with high blood sugar with normal RR and saturation. We examine him. The clinical physician approached the patient. CNS was intact, no queries. CVS and RS was also no queries, no chest pain, no short of breath, not in distress in this term. But abdomen was the culprit organ. He had a tender epigastric, and actually he was preferring to be in the sitting position, leaning forward, and the treating physician noticed an active coffee ground vomitus. The patient was continuously vomiting coffee ground vomitus. He addressed passing stool, but he was not sure about the color. So presence of black stool was not sure it was there or not. So we thought, okay, the treating physician, okay, this is another upper GI bleed. So the treating physician start the management, resuscitation, connected to the monitor, kept him MBO, cross-match sent, analgesia, antiemetic started, uh, PPI also, higher dose of omeprazole, then infusion was started. Then the treating physician was discussing the case with his colleagues, asking, what do you think? How we can stratify such cases? So, is all upper GI cases is severe cases, or some cases are like mild and some moderate? So, how we can say this is mild, can go home, this is moderate, no, this is severe, need to be admitted or need to go for intervention. This is why we have risk assessment tools in emergency. And today I want to share with you one of the risk assessment tools in upper GI bleed, which is Glasgow Blatchford score. This is a very well validated score. It's actually originally modeled in the Scottish population in 1997, then internally validated. Then there was a lot of studies and external validation trials for this tools, and it's one of the well-known and well-established tool for upper GI bleeding, and it's used in most of the guidelines. Then later on in 2017, a group of researchers did some modification in this GBS. They name it as a modified Glasgow Blatchford score. And in this modified score, they just this score is only depend on measurable parameters, not on subjective parameters. To understand it more, I will share with you the Glasgow Blatchford score. This is the original score which contain, as you can see, blood urea. The higher the reading, the higher the score. Then the hemoglobin for men, again, the more drop in hemoglobin, the higher the score. Once it's dropped below 10, the score jump to 6. And then for women, another numbers. Again, low blood pressure, if it's systolic drop below 90, that means 3 points in the score. Pulse, any tachycardia considered as 1 score. And history, if there is a history of melena or history of syncope, they give certain scores for that. And then also, if there is a history of diseases or cardiac failure, give some points. This is um, the original one. The modified Glasgow Blatchford score get out the non-measurable or objectives, subjective parameters that there was some confusion about. For example, syncope. It was a real syncope, or it was like near syncope, or it was like only fainting. So there was some confusion in this part. Again, melena, is it a true melena? He said it's not that black, but it's black, for example. So also it was this why they decide to take it out. Also, history of cardiac failure, is all changes in ejection fraction mean heart failure? No, but people were confused. Same for heart, liver diseases. Not all increase in ALT or AST mean liver disease. This is why the modified GBS take rid of these non-measurable factors and focus only on numbers. So what guidelines said about this factor? About this risk assessment tools, actually, ACG, which is American College of Gastroenterology, which we will mention it a lot in our grand round, as it's one of the well-known guideline in upper GI bleed. It's depend, and it take this GBS score in consideration in their disposition plan. So if Glasgow Blatchford score is 0 to 1, there is less than 1%. This patient will need any hospital-based intervention like endoscopy, blood transfusion, surgery, or even death. So if this is the score, he can be discharged home without patient follow-up. What about our local guideline? When I'm saying local guideline, we are referring to a guideline written by a gastroenterologist in Royal Hospital and recently updated in 2023. In our local guideline, using modified GPS, but taking consideration in modified GPS, the score is zero because now there is no point, there is no, it's all measurable numbers. So you need it to be zero to say it is less than 1% chance that this patient will require intervention and can be discharged from upper GI bleed. If you will use the full GPS, then you need a score of less than 3 to say it's safe for discharge. As you can see, we are a bit higher than the ACG guideline. It could be because some they took in consideration the follow-up plans and how soon we can follow such cases. So that seems great. Now we have a assessment tool that can help us to take a decision for our patient. But what next? Our patient still in the bed. He's still sick. He's vomiting blood. What we can do to help him? Should we call gastro for him? What about giving blood now or later? What about tranexamic? Should we or we should not? So these and similar questions will need the help of our Dr. Fatima Alrawahi, Senior Specialist Emergency Medicine in Nahda Emergency Department, to help us to answer these questions. So, Dr. Fatima, floor is yours.
Thank you very much, Yasmeen, and Assalamu alaikum wa rahmatullah. Welcome everybody to this CME. I am pleased to present about this topic, and let's hop in. I will talk about the evidence-based medicine in regards to upper GI bleeding patients. So I'll talk about four major questions in managing such cases. Is endoscopy urgent versus early advisable for such patients? What about blood transfusion? Is restrictive versus liberal approach is recommended for such cases? The use of tranexamic acid, whether it is advisable or recommended for such cases, and the use of proton pump inhibitors pre versus post endoscopy. Please mind that after each literature review, I will take you through the ACG recommendation as well as the local recommendation. As well as please take into your mind that most of the studies were done in regards to upper GI bleeding, not specifically variceal versus non-variceal. Okay, so we'll start with the timing of endoscopy for upper GI bleeding. We'll talk first about the most famous study that was done, and it was published in 2018 in Hong Kong about the timing of endoscopy. The clinical question was, in patients with acute upper GI and a Glasgow-Blatchford score of 12 or more, does endoscopy performed within 6 hours, which is as an emergency, of gastroenterology consultation compared with endoscopy performed within 6 to 24 hours, have a lower 30-day mortality or not? So they randomized patients into two arms based on the Glasgow-Blatchford score, and each arm contained around 250 patients. They had a total of 500 patients. Okay, so the major outcome or the primary outcome was all-cause mortality, and it was found that all-cause mortality at 30 days showed no statistical significance between the two groups, whether intervention by endoscopy was performed within 6 hours or not. The other outcomes were if there was further bleeding within 30 days or a need of red cell transfusion. There was no statistical significance between the two groups again. And the duration of the hospitalization or the median duration of hospitalization, there was no statistical significance. So this was one of the major studies that was done, and it was a changing study to recommendations by ACG guidelines as well as the local guidelines by the Royal Hospital. There were other studies that were performed, but it was actually not really huge studies with a lot of impact, and I will not go through them. So the ACG guidelines are almost similar to the local guidelines. It is recommended that patients with upper GI bleeding undergo endoscopy within 24 hours of admission to the hospital. However, the Royal Hospital added to that recommendation that patients with higher risk of clinical features like tachycardia, hypotension, bloody emesis, or NGT aspiration of blood, or with a high probability of variceal bleed or with history of malignancy, endoscopy should be recommended within 12 hours. So it can be considered to be done within 12 hours. Okay, so that's it in regards to endoscopy. We'll jump to the next topic, which is blood transfusion, restrictive versus liberal. And by saying restrictive, we mean that we target a threshold of 7. So if the patient has a hemoglobin of 7, then we transfuse. And by saying liberal, if a patient has a hemoglobin of 8, and there are some recommendations later on. So we'll talk about the most famous trial again in this regard. Next slide, Yasmeen. Yeah. So, no, the one before it. So restrictive versus liberal transfusion strategy in upper GI bleeding. It was a randomized controlled trial done in 2017, between 2015 to 2017. And they randomized patients with upper GI bleeding to 2 groups. A group of who got transfusion if hemoglobin is less than 7, and another group if less than 8. They labeled the group less than 7 is restrictive and liberal if the transfusion threshold was 8 grams per deciliter. They looked into 45 days mortality, and it was found that there was no significant difference between the 2 groups. And they looked also into the number of in-hospital bleeding or rebleeding episodes. Also, there was no significant difference between the restrictive versus the liberal transfusion group. Following that, there were multiple RCTs that were also performed in regards to the same topic. However, I thought that involving the systematic review and meta-analysis in this ground would be more yielding. So there was a systematic review and meta-analysis in 2016 that looked into the same topic, and it was found that the number of transfused packed RBCs is actually lower in the restrictive group, as well as the all-cause mortality was lower in the restrictive transfusion group of hemoglobin less than 7 to transfuse. Also, the rebleeding events was lower in the restrictive group. However, there was no statistical significant difference of major ischemic events between the restrictive versus liberal transfusion group. Another study was done in, actually this is 2022. It is a systematic review and meta-analysis, and again, it looked into restrictive versus liberal. It showed that the number of transfusion-packed RBCs was lesser in the restrictive group. However, the length of stay was more in the restrictive group by around 2 days, median of 2 days. The 30 days mortality showed no statistical significance between the restrictive and liberal group, and there was no difference in rebleeding events or the acute kidney injury between the restrictive or the liberal transfusion group. There was a last one performed in 2023 also, and it also showed almost similar findings. The clinical guidelines, we'll talk about American College and the local guidelines. They are almost similar. If you look into it, the threshold of transfusion by American College of Guideline is 7, as well as the local guidelines. However, also our local guidelines recommend the transfusion of platelets of FFP if the platelet is less than 50,000, or if the PT is less than 15 seconds. This threshold is lower for patients with coronary artery disease or patients who are hypotensive with upper GI bleeding. So we should target patients to have a hemoglobin of 8, or if the patient has a hemoglobin of less than 8, then we should transfuse such cases. This is according to the recommendation. Okay. Then we'll go to the next topic, whether tranexamic acid is recommended for such cases. Next slide. We'll talk about the most famous study, which is the HALTED trial, that was a multi-center randomized blinded trial performed from 2013 to 2019. I think it was published in 2019. And the question was, in patients with GI bleeding, does high-dose tranexamic acid, when compared to a placebo, reduce mortality from GI bleeding? The intervention group received tranexamic acid of 1 gram bolus, and then followed by an infusion of 3 grams over 24 hours. And the placebo group received placebo. And they looked into two outcomes mainly, death due to bleeding within 5 days and thromboembolic events. So the first outcome was death due to bleeding within 5 days of randomization. There was no statistical significance between the groups that received tranexamic acid or placebo. And in regards to major thromboembolic events like PE or DVT, it was found that the tranexamic acid group had a higher rate of such events. Hence, the conclusion was that tranexamic acid does not reduce death from GI bleeding and should not be used as part of a uniform approach to treat GI bleeding patients. After that, also, there were multiple studies, RCTs, done to look into the same topic of tranexamic acid in GI bleeding patients. In 2019, there was a systematic review and meta-analysis that included 8 RCTs, a total number of around 13,000 patients. And the conclusion was that tranexamic acid decreases the need for surgical intervention to stop the bleed. However, there was no difference in number of blood transfusion or risk of thromboembolic events or the effect on mortality. Another systematic review with meta-analysis was done also in 2021. It involved 13 RCTs with a total number of around 2,200 patients. And the conclusion was that tranexamic acid reduced the rates of continued bleeding, and it reduced the urgent need to endoscopic intervention. The last one was published in 2023 in just one website. It's actually a small journal, local journal. It was also a systematic review and meta-analysis. It involved 14 RCTs with a number of patients, around 9,300 patients. And the results were a little bit shocking this time. So they said that tranexamic acid does not reduce mortality in patients with acute upper GI or lower GI bleeding. And also they said that it may actually confer to an increased risk of seizures, which is questionable. The second conclusion was that no difference in rebleeding, need for surgical intervention, endoscopic intervention, transfusion requirement, length of stay, or increased risk of venous thromboembolic events. Okay, saying that, we can see that the data is really conflicting regarding tranexamic acid in upper GI bleeding. So both at the ACG guidelines and the local guidelines do not recommend to use it in upper GI cases. Okay, so the last topic will be about proton pump inhibitor, whether we should use it pre or post endoscopy or in both. And when I searched in literature, I found two major studies that can be of impact to our practice. The first one is on your right hand, that was published in New England Journal of Medicine. And it looked into the use of omeprazole, high-dose omeprazole before endoscopy in patients with GI bleeding. And it was a study that was done in 2007, so it is an old study. It involved around 600 patients with randomization to each arm of around 300 patients. And it was a double-blinded, placebo-controlled randomized trial. It was a single center trial. It was found that infusion of high-dose omeprazole before endoscopy reduced the need for endoscopic therapy. However, there was no significant difference in blood transfusion need, recurrent rebleeding, emergency surgery, or 30 days mortality. The other impact was actually by the Cochrane study, Cochrane review that was published in 2022. that looked into the effect of proton pump inhibitor treatments that if it is started before endoscopy in upper GI bleeding. And the conclusion was that it's uncertain still whether PPI before endoscopy affected the risk of death, recurrent bleeding, need for surgery, time to discharge, or blood transfusion requirement. However, it may probably reduce the need for endoscopic treatment of bleeding. So, what does the recommendation of guidelines say? The ACG guideline, I need you to focus here that we have PPI pre-endoscopy and post-endoscopy. So PPI pre-endoscopy, the ACG guideline states that still there is no recommendation of use of PPI before endoscopy. However, our local guideline states that pre-endoscopy IV PPI of high dose 80 mg bolus followed by 80 mg per hour, followed by an infusion, that infusion or 40 mg IV as 2 doses per day should be started immediately in ED and followed after, and then there is another recommendation of post-endoscopy. So the recommendation of post-endoscopy, ACG guidelines recommends high-dose PPI therapy continuously given or intermittently for 3 days after successful endoscopic hemostatic therapy of a bleeding ulcer. Our local guidelines also states all high-risk lesions, which is almost similar to that ACG guideline, if there is a bleeding ulcer by Forest classification, should continue PPI infusion for 72 hours. And that's it. I covered my evidence-based medicine topic. I hope that was helpful. Thank you very much.
Thank you, Dr. Fatima, for such informative part. So I think all of us now feel so confident dealing with upper GI bleed. There is no question we cannot answer. And thanks for Dr. Fatima to this. But that changed when the staff nurse handed to you the ECG for the patient you asked for, and that was the ECG. So the treating physician and the team was like, now we have seen everything. So as you can see in this ECG, it's a diffuse ST elevation MI involving septal, lateral, and inferior walls. So again, we'll go from the beginning. What should we do now? We have a patient who is in front of us vomiting up blood, and his ECG said he have ST elevation. So should we take this patient to cath lab, saying that the culprit organ is the heart, and because the ischemia was so bad, he vomit, and then it's like causing a malarious tear, and this is why he is vomiting blood? Or we can think like this patient is having an active bleeding, his hemoglobin is dropped, and that caused him ischemia, and this is a type 2 MI, or we can say demand ischemia. So we should treat the main cause. We will be in this dilemma. So let me hear from you. What do you think? Where should we go in this case? I will ask you to scan the barcode. Immediately, it will take you to the page to choose what you will do. It will be anonymous. It's just a brainstorming. Where should we go? Cath lab or endoscopy room? Okay, we have some people saying endoscopy, cath lab, so it's a difficult decision. Okay, cath lab is winning. Endoscopy, anybody's thinking endoscopy and cath lab? Only 8, we have 50 participants waiting for more to participate. So it's MI, but he's bleeding. In MI, don't forget in the cath lab, we will use a high doses of anticoagulant. If the main source is the bleeding, he may die on table. And if he has a true MI and you took him to endoscopy, that is not a good decision also. So it's a really difficult decision. So 16, okay. 16, cath lab is winning. You are scared about the heart, huh? Okay. Don't underestimate the gut. They can bleed as hell from gut. Okay. Cath lab still winning. Any more participate? Okay. I think we have to move. So as you can see, it's not an easy decision. It's not like a one person can say confidently, "Oh, that's so clear. It's SD elevation. Take him to cath lab," or the opposite. It's very difficult. And you can see that the you all as audience, as a brilliant emergency physician, you are all have the same concern. So, what guidelines said? Uh, no clear guidelines, unfortunately. Cardiac guidelines, AHA, depend on a case report of a case STEMI with overt GI bleeding in patient with both. Managing the conflicting goals related to the appropriate anticoagulation is a dilemma, which need full assessment of risk and benefits of each condition individually. So they didn't give you any recommendation. It's you and your case, and you decide what is the benefit and risk in each case. So there is no clear recommendation. Then in ACG, no clear recommendation. They didn't mention such presentation. Also in our local one. So if you face it, you are alone. Of course, yeah, and you have the other teams to help you. What about studies? There was a small observational study published in an NIH journal, and in this study, it's saying management of patient with simultaneous overt GI bleeding and MI with ST elevation priority endoscopy. So they said they were advertising that treat the cause, take him to endoscopy. But this was a weak study, although they said it's safe to do BCI for a STEMI patient. But we cannot give any recommendation based on such a small and weak study. It's not a professional study. Before I tell you what happened to the patient, I want we did one more step, which is chest X-ray. And why we want chest X-ray in this case? Actually, we were looking for this. I'll give you a moment to see this X-ray. Yes, you are right. As you can see, there is a pneumoperitoneum. There is an air under diaphragm. This is a chest X-ray in a standing position or sitting position. Should not be in supine. And it showed air under diaphragm. But this was not for this patient. Luckily, it was from the same night from another patient with upper body bleeding with perforated viscous, but not this patient. Our patient X-ray was normal, alhamdulillah. So why we mention the X-ray? Because it's very important to do it. X-ray is very sensitive to big air under diaphragm. In some resources, I found it's up to 80% sensitivity. So it's a simple study, and it can change the whole management from endoscopy or observation to OT. So don't underestimate the power of X-ray in this cases, and go ahead and do X-ray for all GI bleeders, especially for those who have epigastric tenderness and pain beyond what it seems only GI bleeding. So I know you want to know what happened to our patient. So the patient, the case was discussed with the cardiologist in Royal Hospital. They advised not to load him. Usually, we know when there is a STEMI, we load with a dual antiplatelet. This case, we did not load, and they said send him to cath lab. What they found in cath lab, RCA was 80% stenosed, and LAD was 90% stenosed. They did a PCI to LAD with 2 drug-eluted stents. Actually, they planned to do RCA as well, but the procedure was aborted because the patient kept vomiting in the cath lab, and they planned to do it before discharge. And because the patient continued to have an abdominal pain and vomiting, but it was non-bloody after a while, they consulted a surgical team in Royal Hospital. So they did CT angio to rule out bowel ischemia and perforation, and that was ruled out. Then patient was still symptomatic. They refer him to gastro team so to evaluate his need for endoscopy. But gastro said as the hemoglobin was stable, this hemoglobin was, patient hemoglobin was 13. And if we go back to his Glasgow Blatchford score, it came as 1 only because he was tachycardic. The rest of investigation was all normal. So, but if it is modified, a Glasgow Blatchford score, it will be 1, and it's considered unsafe to go home in as per our local guideline. Anyway, gastro said no active intervention. The patient hemoglobin is stable, and he is not vomiting blood anymore. Patient kept for several days in the hospital. Echo was done. Unfortunately, ejection fraction showed 35%, and there was left ventricular thrombus. He was taken to cath lab, BCI done to the RCA. His abdominal pain and vomiting improved gradually, and then he was discharged on dual antiplatelet, but no anticoagulant was given to him. So this case was about STEMI with Mallory Westier. This was their impression. It started as a body I played, but it ended as STEMI. So I hope it was clear, and let's conclude and summarize whatever we talk about. In upper GI bleed, it's very helpful to use a well-validated risk stratification tool, which is Glasgow Blatchford score or modified Glasgow Blatchford score, to help you to decide should this patient go home or should patient admitted, and if any urgent intervention is needed. The higher the score, the worse the outcome and the presentation. Then Dr. Fatima thankfully explained to us the endoscopy timing. It's not like a need for urgent endoscopy within 6 hours. Doesn't change anything if it's done within 24 hours, as long as the patient is relatively stable. Blood transfusion, again, it's not like you want to save the patient, so you will give blood regardless of the hemoglobin. No, too much blood can be harmful, as Dr. Fatima explained to us. So restrict blood transfusion to hemoglobin below 7, unless if the patient is coronary artery disease or hypotensive, then the threshold can be 8. Tranexamic acid, there is a lot of conflict and researches, but till now, no recommendation to use it in upper GI bleed. BBI, although we used to give BBI for all upper GI bleed, international or American guidelines, they cannot prove it's beneficial, but they are not suggesting not to do it. So our local guideline advice to start BBI pre-endoscopy, and that may reduce the need for endoscopy, although it will not change the need for blood or need for surgery or mortality rate. In case of upper GI bleed and STEMI, this should be a take-home message in any patient with epigastric pain, and even if you are 100% sure this is upper GI bleed, you have to do ECG, because it can you may be wrong. So ECG is a must. And if it is happen to be an STEMI case, then evaluate each case individually and risk and benefit, measure the risk and benefit, and always consult the expertise. Involve both teams to take a best decision for the patient. And remember, you have to follow your guidelines for best management for your patient, and keep your knowledge up to date, because what we say today may be changed by tomorrow. This is the reference. We use it in our presentation. And the credits for this slides. Thank you. And I want to hear from you if you have any question. If you don't want to talk, you can just scan this barcode and write your question, and we will read it and answer it, inshallah.
Great. Thank you very much, Dr. Yasmeen and Dr. Fatma. That's really a tough case. Now, I think Dr. Sakina actually raised her hand early on. So I'm just opening the floor for Dr. Sakina if you want to speak up or write down the question or write it down in the barcode also, it's totally okay, up to you. Go ahead.
Thank you so much, Dr. Yasmeen, Dr. Fatima. It was very interesting and tough case. I just had a question. Was it possible to do both procedure at the same time? For example, while performing the PCI, was it possible to do the endoscopy?
As I know, it's totally different setting, endoscopy room than the cath lab, and I don't think this is visible. Um, we need to ask the expertise, but I can imagine both procedure. I don't think this is visible, and it's not only about the timing of procedure; it's about the management. You are trying to stop bleeding in endoscopy, but in the cath lab, you are giving anticoagulant, higher doses for anticoagulant. So it's like you are conflicting. The two things is conflicting each other, but doing two procedure at the same time, I don't think so. But we need to confirm from expertise.
Thank you so much, Sakina, for the question. To answer this question as well, adding to what Yasmeen said, if you notice that I involved a slide about endoscopy timing. So gastro, they don't prefer doing endoscopy to such cases unless the patient is really hemodynamically unstable. And by saying that, we also involve the high-risk group in the Royal Hospital guideline. They involve the group that will need endoscopy within 12 hours. And they didn't state that such cases will need endoscopy as an emergency, but they said it's early, so within 12 hours. Probably that's why they went for the PCI, CAG and PCI prior to doing endoscopy. And I agree with Yasmeen, it would be a totally different setting. The PCI room is totally different. It's not prepared to do endoscopy at the same table.
Okay, Yasmin, if you have any questions you received, okay, Shuga, Dr. Shuga, go ahead.
I'm Dr. Shuja from Khuriyat Hospital. Thank you, Dr. Yasmeen and Dr. Fatima, for an excellent presentation. Regarding upper GI bleed, you briefed us about risk stratification, the timing of endoscopy, the role of PPIs and restrictive blood transfusion. And I wanted to know what's the role of gastric lavage for these patients, number one. Second is use of drugs like octreotide. And third, the role of antibiotics in decreasing the mortality or the clinically relevant endpoints. Thank you.
Thank you so much, Dr. Shuja, for the question. So let me just review what you said. The questions you asked about use of octreotide as second question, antibiotics, and the first one
Antibiotics and
was?
gastric lavage.
And gastric lavage. Okay, this is really interesting. So in regards to the American College guidelines, they didn't specify the use of gastric lavage. However, because I went extensively into the management, even in pediatric cases, they recommend that there are some literature recommendation of aspiration and lavage only in infants, just to give that diagnosis of patient really having an upper GI bleeding. But there is no recommendation of gastric lavage, and there is I don't think that it would do anything to the outcome of the patient. In regards to octreotide and antibiotic, please notice that we are talking only about the non-variceal upper GI bleeding in this presentation. So today we spoke about the evidence base behind non-variceal bleeding, and role of octreotide and antibiotic, it doesn't exist in such cases. It only exists in variceal upper GI bleeding. So if you have a patient with bleeding of fresh blood, you're not sure whether this is variceal or non-variceal, then I would recommend use of octreotide and antibiotic in such cases, because they actually change the morbidity or mortality of such cases. But in non-variceal, in patient who is having coffee ground vomiting, no, there's no role.
So I will just say what the same what Dr. Fatma said, that If you are not sure and there is no evidence, and there is, like in our patient, there was nothing suggestive of hepatic diseases. There is no previous liver disease. He is not alcoholic. There is no ascites, nothing. So I don't know what's going on, but I didn't think it is a varicose. This is why we didn't give the management, which is octreotide and antibiotic. But if the case is not, the patient can be very complicated. Like this is your first time to see this patient. There is some ascites, there is some chronic liver disease signs in his body, plus maybe liver labs showed some derangement in LFT. You have the suspicion, then go ahead and treat, because you don't have endoscopy in your emergency to diagnose this is varicose or non-varicose. If you have suspicion this could be a variceal bleeding, then yes, there is a rule for octreotide and there is a rule for antibiotic. Otherwise, no rule.
There is a question that's raised in the poll to Yasmeen. Did you find difficulty in transferring the patient? And I will add to that just one more question. Did you find difficulty in convincing cardiologists?
No, not at all. With that ECG, it was enough to convince anyone in the earth this is STEMI, and they were very cooperative. The patient was relatively stable during transfer. A doctor escorted the patient. Yeah, it was smooth. Any more questions? Story to be shared? Any comments? You can just scan the barcode and write your question or your comments or whatever, or a story to share. Have you ever seen elevation with upper GI bleeding? Anyone saw both cases together? Because we went through the literature, it's very rare. So we want to know, is it like in Royal Hospital people, have you ever, any one of you treat case like upper GI bleed and ST elevation MI at the same time, and how it was?
I remember I have seen a case in SQ during residency, and it was actually managed the same way. By cardiologists, they took the patient to cath lab, then admitted to Heidi, and after like 6 to 12 hours, he was taken to endoscopy. So it was managed actually the same way.
Interesting. There is a question, was the patient intubated before transferring? No, he was relatively stable. No, we did not intubate him. Any more stories? So if there is no more questions, I think I will ask you to rate the grand round by scanning again the barcode and tell us what you felt about it. It was boring, it was okay, or it was, you think you benefit from joining us in this grand round.
Yes, while everybody actually doing his rating, I'm just going to highlight that this ground round, we're just starting slowly on it. We are encouraging everybody to join us if they actually benefit from such a collaboration. And coming ground round, inshallah, will be actually done by Khawla Hospital and Royal Hospital. But I think before we end up, there is actually a raised hand by Dr. I'm not sure if it is Dr. Bina and Dr. Naeem Al-Hanai. So go ahead, Bina. Is it Dr. Bina? Am I right?
There's also Dr. Suhail raising hand.
Right, and Dr. Naima I saw also.
Yeah.
So Dr. Naima, go ahead.
Thank you, Dr. Suad. Actually, I don't have a specific question, but I would like to thank you all for this arranging this grand round, which is very helpful in collaborating all the emergency departments gradually, as you said. It sounds very interesting case. Yasmeen asked about if we encountered upper GI with STEMI. I don't remember that I encountered this, but I encountered DKA with STEMI, in fact. So again, and emphasizing on the point that lots of time maybe you need to think about, you need to think out of the box, yani, on sorting out patients. Thanks again.
Thank you, Dr. Naima.
Also, I actually encountered one trauma case, an elderly who came in a trauma code, and then we figured out that he was an ST elevation MI in the same settings. So I would actually really reduce the hour threshold of other differential diagnoses, and I actually don't think anything inside the box. Just drop the box out and think really broad in differential diagnosis. That is emergency, and that is the way it's supposed to happen. Dr. Suhail, is it? Is it Dr. Suhail who wants to ask a question? Please correct me if I'm wrong.
While we're waiting for Dr. Suhail, just for the sake of completion, we can find also upper GI bleeding in even pediatric cases. So the pediatric cases also, we follow the same guidelines of high dose PPI before. So this is what I found in the literature. It's not including in the American College guidelines, American College of Gastro. But I tried also to search in the literature about pregnancy. Unfortunately, I couldn't find any specific recommendation of how to manage upper GI bleeding in pregnant cases. You know, these special populations, sometimes they come actually with this and you're not sure how to manage such cases. But I think if you are not sure how to manage, then you just follow the American College guidelines and it will take you through that.
Great. Then we're just gonna open the discussion, open for a floor for question. If no questions, we can actually wrap up and end up the day. Let me double check before we end up. Yes, I think we're good. Thank you very much, Dr. Yasmeen, Dr. Fatima. It was really a great case, and we hope to see you in the next and the coming ground round of emergency medicine. Thank you and have a good evening.
Thank you very much.